Events in the third stage of labor. Third stage compromises the phase of placental separation. It descends to the lower uterine segment, finally its expulsion with the membrane. Mechanism of separation. Marked retraction effectively reduces the surface R at the placental side to about its half. The plane of separation runs through deep spongy layer of Decidua bacillus. There are two ways of separation of placenta. Central separation, full detachment start at the center. Marginal separation, Matthews-Duncan separation start at the margin as it is mostly unsupported. Separation of membrane facilitated partly by uterine contraction, mostly by weight of the placenta. Expulsion of placenta, expelled out by either voluntary contraction of abdominal muscles or by manual procedures. Placenta in the third stage of the labor. This is a pictorial presentation mechanism of separations of the placenta. This is Schultz and the Matthews-Duncan's method. Mechanism of control of bleeding. Uterine vessels occlusion is affected by complete retraction, whereby arterioles, as they pass tortuously through the interlacing intermediate layers of myometrium. It is known as a leaving ligature, is the principal mechanism of the hemostasis. Mechanism of the normal labor. The series of the movements that occurs on the head in the process of adaptation during its journey through the pelvis is called mechanism of labor. Head enters the brim more commonly through the available transverse diameter. Left occipito anterior is the little commoner than the right. The engaging transverse diameter is biparietal, that is 9.5 centimeter. These are the principal movements that occur during the mechanism of labor. One is engagement, descent, flexion, internal rotation, crowning, extension, restitution, external rotation, and the expulsion of the trunk. Steps of mechanism of labor. Engagement. In primary gravida, engagement occurs in a significant number of cases before the onset of the labor. While in multiparous patients, the same may occur in the late stage with the rupture of the membrane. Descent, it is a continuous process. Factors facilitating the descents are the uterine contractions and the retraction, maternal bearing down effort, straightening of the head, fetal ovoid, especially after the rupture of the membrane. Flexion is achieved either through the resistance offered by the unfolding cervix, wall of the pelvis, or by the pelvic floor. Lever action producing the flexion of the head, reducing the engaging diameter of the head from the occipitofrontal to the suboccipitobradmatic. Head brim relation prior to the engagement, anterior parietal presentation, head in cyclitism. C picture present the posterior parietal presentation. Internal rotation, majority rotation occur at pelvic floor. In occipitolateral position, there will be anterior rotation by the 2/8 of the circle of the occiput. In oblique anterior position, rotation will be 1/8 of the circle forward, placing the occiput behind the pubic symphysis. Torsion of the neck, it is inevitable phenomena during the rotation of the head. In anterior posterior diameter, neck has to sustain a torsion of 2/8 of the circle, but neck fails to withstand such major degree of torsion. So there will be some amount of simultaneous rotation of the shoulder in the same direction to the extent of 1/8 of the circle. Extension delivery of the head take place by the extension through the couple of force theory. Restitution, it is a visible passive movement of the head due to the untwisting of the neck sustained during the internal rotation. Restitution occurs rotating the head through the 1/8 of the circle direction opposite to the internal rotation. External rotation of the head visible externally due to the internal rotation of the shoulder. Degree of this picture will represent the degree of rotation of the restitution of the head. This is the head is delivered by the extension. Head at the vulval outlet. This is the crowning. This is a step showing the mechanism of the labor. Head is borne by the extension. Head drop downs with the face close to the anus. Then restitution occurs and external rotation occurs. Now the delivery of the shoulders by the lateral flexion occurs by the anterior shoulder. First anterior shoulder is delivered, then the posterior shoulder is delivered. Clinical course of the first stage of labor. The first symptom appears is intermittent painful contraction followed by the expulsion of the blood-stained mucus shows per vaginum. Pains are not strong enough to cause discomfort and come at varying intervals of 15 to 30 minutes with duration of about 30 seconds. But gradually the intervals become shortened with increasing intensity and duration so that in the late first stage, the contraction comes in an interval of 3 to 5 minutes and lasts for 45 seconds. Clinically, the pains are said to be good if they came at intervals of 3 to 5 minutes and at the height of the contraction, the uterine wall cannot be tended by the finger. Dilatation and the effacement. Cervical dilatation relates with the dilatation of the external os. Effacement is determined by the length of the cervical canal in the vagina. Partograph, it is a complete graphical or pictorial record of the cervical dilatation and descent of the head against the duration of labor in hours. This is the picture presentations of the partograph. Now, the status of the membrane remain intact until the full dilatation of the cervix or sometimes even beyond. In the second stage, it may rupture at any time after the onset of labor, but before full dilatation of the cervix called the early rupture. When membrane rupture before the onset of the labor is called the premature rupture of the membrane. Head is palpable fifth by fifth above the cervix symphysis. Head is mobile, free and not engaged. If the head is palpable 2/5 above and 3/5 has gone down the brim, the head is engaged. This is a picture that shows how to assess the engagement end of the head per abdominally. Clinical course of second stage of the liver. In pain intensity increases, bearing down efforts. It is the additional voluntary expulsive efforts that appear during the second stage of labor. Sustained pushing beyond the uterine contraction is discouraged. Membrane status. Membrane may rupture with a gush of like a vagina. Now the descent of the fetus. Features of the descent of the fetus are evident from the abdominal and vaginal examination. Abdominal functions are assessed in relation to the brim. Internal examination reveals descent of the head in relation to the ischial spine. This is a picture presentation. Clinical course of third stage of labor. Pain for short time, intermittent discomfort in the lower abdominal reappears corresponding with the uterine contraction. Before separation, uterus become ovoid in shape, firm in feel and non-palatable. Fundal height reaches slightly below the umbilicus. After separation, it takes about 5 minutes in conventional management for the placenta to separate. Uterus becomes globular, firm, and palatable. There may be slight gush of vaginal bleeding. Permanent lengthening of the cord is established. Expulsion of the placenta and the membrane. Expulsion is achieved either by the voluntary bearing down efforts or more commonly aided by the manipulative procedure. The afterbirth delivery is soon followed by slight to moderate bleeding amounting to 100 to 250 ml. Now, the management of the normal labor. It aims at maximum observation with minimal active intervention. Antisepsis, asepsis, vaginal examination in labor. First examination is always by the senior doctor to be more informative. Preliminaries, cleaning, sterile pair of gloves, vulval toileting, glove, middle finger and the index finger of the right hand. Now, the following examination are to be noted and recorded carefully. Degree of cervical dilatation in centimeters, degree of effacement, status of membrane if ruptured if ruptured color of the membrane, presenting part and its position, caput or the molding of the head, station of the head, assessment of the pelvis. This is how to assess the station of the head in relation to the ischial spine. Management of the first stage of the labor. Principal non-interference with the watchful expectancy to monitor carefully. Actual management, general antiseptic dressing, encouragement, emotional support and assurance, constant supervision. Rest and ambulation. Patient allowed to walk if membrane intact. If prevent venicaval compression, facilitate descent of the head. Liquid oral diet intake allowed in early stage. Food withheld in active stage. IV fluids given. Bladder care. Bladder distension to be avoided. Encouraged to pause urine by herself. Relief of pain. Abdominal palpation, pelvic grip and uterine contraction. Frequency, duration, intensity. Fetal well-being monitoring by fetal heart sound measurement. Maternal vitals, temperature, pulse, BP. Assessment of progress of labor and the photograph recording. Maternal position lateral recommended and is mostly comfortable. Evidence of maternal distress are anxious look with sunken eyes, rising pulse rate 100 per minute or more, dehydration, dry tongue, hot dry vagina, often with offensive discharge, acetone smell in breath, scanty urine. Management of the second stage of the labor. Principle is to assist the natural expulsion of the fetus to prevent a perineal injury. General measures are constant supervision, administration of analgesic, vaginal examination, preparation for the delivery, position, dorsal position with 15-degree lateral tilt is preferred. Toileting of external genitalia. 3 C's: clean hand, clean surfaces, clean cutting and the ligature of the cord. Catheterization the bladder if full. Conduction of the delivery is 3 ways: delivery of the head, shoulder and the trunk. Delivery of the head. The principle to be followed are maintain flexion of the head to prevent its early extension, regulate its slow escape out of the vulval outlet. The patient is encouraged for the bearing down efforts during the uterine contraction. This facilitates descent of the head when the scalp is visible for about 5 centimeters in diameter. Flexion of the head is maintained during contraction. This is achieved by pushing the occiput downwards and backwards by using thumb and index fingers of the left hand while pressing the perineum by the right palm with the sterile vulval pad. This is how to assert the delivery of the head. Prevention of the perineal laceration. Delivery by early extension to be avoided. Forcible delivery of the head is to be avoided. To deliver head in between contraction, perform timely episiotomy. Take care during delivery of the shoulder to immediate care of the newborn. Delivery of the shoulder, not to be hasty. In delivery of the shoulder, wait for the uterine contraction to come. If there is delay, the head is grasped by both the hand and gently drawn posteriorly until the entire shoulder is released from under the pubis. By drawing the head in upward direction, the posterior shoulder is delivered out of the perineum. The traction on the head should be gentle to avoid the injury. Delivery of the trunk, the forefinger of each hand are inserted under the axilla and the trunk is delivered gently by the lateral flexion. This is a presentation of how to deliver the anterior and the posterior shoulder. Management of the head. Management of the third stage of the labor. Principle, it is the most crucial stage of the labor, mainly to prevent postpartum hemorrhage. Steps of management, expective management and active management. Method of expressions of the placenta. It's by the fundal pressure and by the controlled contraction, the placenta is expelled. Scheme of management of the third stage of the management, expected management. After the delivery of the baby, clamp, divide and ligate the cord, wait and watch, catheterize the bladder if needed, guard the fundus, wait for the spontaneous separation of the placenta. Placenta gets separated, wait for the spontaneous expulsion with the aid of the gravity. If fails, an assisted expulsion can be done. In the active management, injection oxytocin 10 units IM or injection methagen 0.2 milligram intramuscular to the mother is given within 1 minute of delivery of the baby. Clamp, divide and ligate the cord to deliver the placenta by control contraction soon after the delivery of the baby, availing the first uterine contraction. If it fails, then repeat after 2 to 3 minutes. If again fail, then wait for 10 minutes, repeat the procedure. If fails, again fail, then manual removal is done. Injection oxytocin slowly IM or methagen is given. Then examine of the placenta and the membrane to inspect the vulva and the perineum. Thank you.